I'd just like to, I haven't got very long, and I'd just like to address some of the basic issues around, I think, the two themes that came out of Craig's talk, very interesting talk. One is the sort of changes that he described and how we respond to those. But also the metadata use he's talking about, all of which is extremely important and fascinating. The data that we're going to aggregate for whatever purpose comes initially from patients and is collected by doctors and other healthcare professionals. So we have to sort of look at the small and the large at the same time and try and in some way make that process of data collection, data creation, sharing consistent and make it in the interests of patient care. I belong to a profession that's regarded as really quite sort of dinosaur-like in its reactions to change, which I think is not entirely fair, because we obviously as doctors have to adapt enormously to changes in the evidence around healthcare. And I think if I was still attaching leeches to my patients or injecting them with mercury, I probably wouldn't be getting on that well as a doctor. But I also think that if you want to sell the benefits of any treatment or any technology to doctors, you probably want to do three things. You want to show that it's going to be a benefit to patients. You also want to show that it's going to be beneficial to the budget of the doctor, preferably not impacting on it at all. But you also want to make it easy to use and interactive. And if you can do those things, then I think you've got the medical profession at least interested and more on your side. But if we look at the background to the changes that are occurring and the changes we need to react to, we've got some pretty fundamental ones. We've got patient demands and expectations to have more control over their records, over their health and over their care. We need relevant information to improve shared care, both across medical and social care boundaries, but also patients to become part of the healthcare team. We need to recognise that chronic care treatment is as much social as it is medical. But chronic illnesses derive from a background that's in the social determinants of health, of ill health. And we spend more and more on health care to correct those things that in many, many cases were not entirely preventable, but certainly preventable by much smaller interventions earlier on. And the work that's been done, for instance, by Sir Michael Marmot on the social determinants of health demonstrates that if you tackle fundamental inequalities of health, inequalities of income, you will generate better health. But there is no policy around that. But one of the things that would drive effective policy around that would be the metadata that would prove to politicians that it would work. In the same way, for instance, that one of the huge challenges that we face, and I suggest that if we don't believe in climate change, we better believe in at least having a solution to it, if only for the precautionary principle, because the latest projections are this planet will not sustain human life beyond 2500. If you believe that, then we obviously have a problem of addressing that. But if we had the data that told us where to spend the money on green technology and the impact that would have on health, we would be a lot more secure in making political and financial and funding decisions. And for instance, I've been involved in a report that came out a few months ago demonstrating on climate change that if the European Union went from a 20% reduction in greenhouse gas emissions to 30%, it would cost around 45 billion euros a year to do that. You would very quickly recoup healthcare costs of around 30 billion a year within about 2 or 3 years. So if you can do that just in terms of the technology on greenhouse gas reductions delivering healthcare benefits, that's extremely attractive. But you also need to be able to measure where you would put that spend. And this metadata usage is clearly pivotal in that. We've also seen challenges to healthcare professionals in describing what they actually do. There have been a number of projects, mainly using telemedicine, which have, as a result of the projects and the work done, created new types of healthcare professional, people who sift data, people who explain risk to patients, people who manage patient referrals back into the system and point them into the right intervention, people who look at home-monitored ECGs and give advice to patients about adjusting their dosage. In those sort of projects, you see a massive reduction in the acute admissions for congestive heart failure, for instance. And these are new types of healthcare professional who need different types of training. And if we begin to see the way in which healthcare will be delivered as a result of the use of data to direct prevention, to direct self-management of care, to join up chronic healthcare delivery, then you begin to see a move more from healthcare towards health and wellness that Craig mentioned. You focus more on prevention rather than treatment. And you certainly change that relationship that the patient has with the healthcare system, where instead of the patient being what doctors sort of call compliant, in other words, has the patient behaved according to my directions, and if not, they're a really naughty patient, to one of engagement with the healthcare team. And that partnership cuts through many of the silos that take place, both at specialty level, hospital level, and primary care level. And we will see more care moving into the community because it can be monitored better in the community than in hospitals. And that's what we might call a more holistic approach to healthcare. Now, I think that change in the way that, it's not just the way that the doctor-patient relationship changes, it's the way the patient's care is delivered in a completely different context by a different type of healthcare system. I hear what Craig said about the concept of the electronic patient record perhaps being a little bit passé, but let's not forget that that is a major, if not the major vehicle for the care of patients. And I think it's already moving from being a rather passive set of data that you might access if you're a doctor or a nurse, or access if you're a researcher or for financial audit, through to something that's much more iterative and interactive. And I think if we start to see the electronic patient record used as a vehicle for information transfer, particularly to patients, particularly relevant information to doctors, I would love to know what the impact of a decision I make about treating a patient actually is. You know, I'd like to see what other doctors have achieved by doing what I'm doing, the test I've ordered, the drug I've given. And it could be delivered to my computer screen in a way that would be very sophisticated but also very practical. And I think that if you look at the value of that electronic patient record allied to more patient control over their record, and I'm actually an advocate for patient ownership of data. The information we're using about patients belongs to them. I happen to own the system on which the data is held. Now, who owns the data? It seems to me to be obvious. It belongs to the patient. But I'm the guardian of it, but I'm also responsible for making sure that that information is shared appropriately in the patient's best interest. And patients are often rather surprised that we don't share more information about them for their health care, whereas doctors tend to be rather cautious about doing that at all. And there's a mismatch there between the professional view and the patient view. One of the issues, of course, and Craig mentioned this, is about privacy. We're seeing the beginnings of a consultation over the change to the data protection regulations, but a lot of that is around the law of privacy. It's very important, I don't deny that, but it's a tool to punish. The law is a tool to punish people who inappropriately share data. And actually doctors are much more frightened of their regulatory bodies, who will actually remove their ability to work as doctors if they inappropriately share information about patients. And what we're more interested in a sense, is the more practical, ethical approach to data management, which is based on the primary ethical principle of the four great ethical principles. Autonomy is the most important, the right, as far as I can, to direct what happens to me and have control over my life. If you want to practice autonomy in a practical way in healthcare information, then you have to get consent and you have to observe confidentiality. And one of the huge challenges that we face is that the more data that's flowing around, the more the potential exists to use data collected in the context of patient care, but then reused in a secondary way for research, for financial management, for clinical audit, what level of consent is required from the patient for us to use that data, not for their care, but to improve the care of people like them, or improve the care of populations in terms of public health. Those are big ethical principles that actually have huge practical challenges that we're trying to address. And I'll just finish on how we're trying to address some of those, because there are some major projects taking place. As you may know now, we've got the EPSOS project, which is prescribing data across borders and limited summary care records across borders. We've got the Calliope project, which just finished, on interoperability, and many of the outcomes of that have been taken up by the new eHealth governance initiative, in which I'm chairing one of the working groups, where the roadmap from Calliope is going to come into a much more practical focus. We've got other projects like Renewing Health, the European Patients Forum Chain of Trust, and of course the latest iteration of all this is the Commission's project on healthy ageing, which is highly IT focused. I think we have to be careful that we decide what we want to learn from all these projects, rather than set up the projects and then find out what they tell us. And some of the things we need to learn are the usability of the technology, both at the micro level, the doctor and the patient sitting in a room, sharing information, using evidence-based data to inform the patient and to inform the doctor about the best outcomes for treatment, involving the patient in their care. And you step back from that and you look at the use of huge amounts of data, probably anonymized, for a better understanding about the social determinants of health, health inequalities, climate change, public health measures that will reduce ultimately healthcare costs at the other end, which are simply at the minute mopping up and failing to mop up, because all European healthcare systems are ultimately unsustainable. We've got to find a way of building patient engagement and prevention into the equation, and the best way to do that, at least, is to have the right data. So thank you very much for allowing me to just have those few reflections.